Hello, thank you everyone for joining. I am Deanna Bryan, the program manager at Hope for HIE, and I'm joined today by Dr. Laura Gilbert, who is going to be discussing everything dystonia with us. So thank you so much for being here with us today, Laura.
Of course, thank you so much for having me today. I'm very excited to be here during Cerebral Palsy Awareness Month to discuss this important topic with you all today. And so thank you, Deanna, for having me here. I really appreciate this opportunity.
Yeah, we're really grateful. I can go into all of your credentials and all of the things that make you an amazing resource, but I think that would probably better come from you. So if you don't mind starting off this discussion with just who you are, what you do, and just your journey to becoming a neurologist and how you developed a special interest in movement disorders like dystonia.
Yeah, absolutely. So I am a pediatric neurologist and movement disorder specialist at Ann and Robert H. Lurie Children's Hospital, Chicago. And so my clinical and research interests really focus on specifically dystonia and cerebral palsy. And my interest in movement disorders, interestingly, was informed actually by my time as a professional dancer and dance teacher, where I learned to understand the nuances of the movement patterns of the human body. And then I found a natural home in movement disorders as a clinical research assistant at the Parkinson's Disease and Movement Disorders Center at Northwestern University, where I was an undergraduate student. And this really helped to spark my interest in the field. And then my passion grew during my time in medical school when I realized, hey, I could pursue this, but with children and adolescents. And so in residency, I absolutely loved caring for people with cerebral palsy and their families. And I was very lucky to have had the opportunity to train for both pediatric neurology and movement disorders at Washington University in St. Louis. And that's one of the largest CP and mobility centers, actually. And I trained under 4 pediatric movement disorder specialists. And so in addition to that, I also loved volunteering and kind of combining my passion for dance and medicine with volunteering with adaptive dance classes created by our therapy teams for people with neurodevelopmental disorders.
Wow.
And
that's cool.
Yeah, it was a great way to combine my passion. So, and then in residency, I also became a member of the CP Research Network Dystonia Study Group, where I had been able to have the opportunity to help build a dystonia research agenda driven by input from CP community members. So people with CP and their caregivers and advocates. And this work really inspired me to understand and employ CP community perspectives to improve CP community outcomes and demonstrated the importance of involving community members directly in the research process from the outset. So in partnering with the community now, I'm actually currently working towards understanding community member descriptions of dystonia to help inform community-facing screening tools for dystonia and CP that will hopefully help to improve dystonia diagnosis and access to dystonia diagnosis.
Wow. Well, I feel insignificant. That is amazing. All of the work that you're doing, that's it's unbelievable. And you know, we just had a peer perspective group with parents who met about their experiences with dystonia. And so to hear that in contrast then to all of the work that you're doing to just help improve quality life and just treatment and management for people who are impacted by it, it just hits home. You know, it means a lot. So thank you so much again for being here and explaining it to us and all the work that you're doing. So it's awesome.
It's a privilege for me. So thank you.
I love it. So we're going to get started with just kind of like if you don't mind, just an explanation and overview of dystonia. What is it? How can you explain it? What are some of its underlying causes? And then if you can, how is it relevant to HIE?
So the way that I like to describe dystonia is that muscles are contracting that you do not want to contract when trying to move. So basically, if you try to move, other parts of your body may move out of your control. And this is often described by people affected by dystonia as tightening or stiffening, and it can lead to postures or twisting of different parts of the body, something that we call overflow. And dystonia can also sometimes be triggered by tactile stimulation or stretching. So if another person tries to move them, for example, with dressing or perhaps changing diapers, this can trigger dystonia as well. And interestingly, heightened emotions like worrying, anxiety, excitement, that can also trigger worsening dystonia. And it also, interestingly, does resolve with sleep. So that's something that helps to differentiate it a bit from spasticity too.
Mm-hmm.
Dystonia is therefore variable, but it can impact functioning. It causes pain. It can affect sleep, causes orthopedic complications, and impacts overall quality of life.
Mm-hmm.
And unfortunately, we're still learning about what causes dystonia. So there seems to be some loss of inhibition that is supposed to occur, leading to excess movement and what we call overflow. And though we can sometimes identify the cause of an individual's dystonia, such as HIE, we do not really have a great understanding yet about how dystonia occurs, other than it seems to be a network disorder that may come about when one or more areas of that complex circuit in the brain may be impacted. So CP is actually the most common cause of childhood dystonia. And we know that people with HIE are maybe more likely to develop spastic or mixed CP with dystonia and spasticity rather than other CP subtypes.
Yes. And how does a dystonia diagnosis come about? Maybe signs or symptoms of it for parents, and then also, is there one provider or are there multiple providers who can provide that diagnosis for families?
Yeah, great question. And this is an area that I am especially passionate about, and the area that my clinical research really focuses on. So dystonia is really challenging to diagnose and has largely been under-recognized. So we know actually that in research settings, with trained assessors doing this, up to 70% of people with spastic CP have dystonia. And in comparison, Dr. Bhuma Ramuthan's lab at WashU had found that only 13% of people with known and diagnosed leg dystonia were identified as having dystonia in a given clinical visit. So there is clearly a broad diagnostic gap that we need to be addressing. And so typically dystonia is diagnosed by a neurologist or physiatrist, or maybe recognized by other teams like neurosurgery or orthopedic surgery or a physical occupational therapist. And it can be seen as early actually as infancy, but can also have a delayed onset. So dystonia could be diagnosed during a clinical visit based on particular maneuvers that we use to assess for dystonia that really can bring out dystonia, as well as reviewing videos that family members may capture. So this is important to note, since dystonia, as I mentioned, is variable. A clinician may not see it during a given clinical visit. So it's great if families come in with videos of their child maybe doing different functional tasks at home, and we can take a look at what their movements look like outside of the clinic. And we do have several assessment and diagnostic tools for people specifically with dystonia and CP, but there are limitations to using some of these tools. So for example, the length it takes to perform them, the difficulty in differentiating dystonia from other tone types like spasticity, and overall, there's variability of dystonia characteristics that we may see overall across people. And so we're therefore trying to develop other novel assessments. So for example, my research has really focused on understanding how previously how expert clinicians describe dystonia in the arms and legs when we're viewing videos of children and adolescents with dystonia and CP. And now I'm currently working on interviewing the other experts in the field, caregivers of people with CP. So I'm hoping to understand caregiver descriptions of dystonia, their perspectives and lived experiences with really dystonia throughout the daily life or their day-to-day life. And caregiver expertise is complementary to that of the clinician. So with this knowledge, I'm hoping to build diagnostic tools, novel diagnostic tools built for caregivers by caregivers. And then some other directions to improve diagnosis and measurement of dystonia and CP also includes exciting work like Dr. Bhuma's, where her lab is actually looking at quantitative motion analysis of videos of people with CP. So lots of exciting potential directions for improving dystonia diagnosis.
Wow. That's great to hear that there's all this work to kind of, help that gap for parents and caregivers and clinicians and everything. So as you may know, when it comes to HIE specifically, there's a range of impacts and outcomes. So I'm wondering, we talk about dystonia, do they share that commonality? Is there a range of impacts and outcomes when it comes to dystonia? And if so, what does that look like?
Yeah, there certainly is a range. And so dystonia can range from very mild without any impact on function and only involving one part of the body to really severe generalized dystonia that could potentially impact arms, legs, trunk, neck, face, maybe even voice or speech. That could all potentially be impacted. And the areas of the body affected often relate to areas of injury to the brain. In our research, though, we've found it's interesting. It's more challenging to diagnose dystonia in people who have milder symptoms. And even though someone may have mild dystonia, it can still be impairing functionally, and they may not even realize that it's impairing their functioning. So perhaps it leads to difficulty with writing or with doing fine motor tasks, or it could cause tripping when walking. And so it's really important to detect dystonia of all severity levels as best as we can.
Yes. And I feel like that's a good segue into our next topic, which is how do we manage it? And what are some treatment options? So basically, I'm just going to repeat it. What are the available management and treatment options for individuals who are diagnosed with dystonia?
Yeah. So when I think about management options, I sort of separate potential treatments into three main categories. So one being pharmacologic or medications, another being surgical, and then another being other rehabilitative or psychological approaches. So for pharmacologic management or medications, I typically consider starting a medication after discussing with the person with CP and their family about whether the dystonia is causing them any impairment of their functioning, whether it's causing discomfort, maybe it's impacting their sleeping. And so this is important to consider because unfortunately right now medications for dystonia are imperfect, and we do not typically see complete control of dystonia with medications, and they often can cause side effects that also can limit functioning. So there are several medications, though, that we do typically consider. And according to the American Academy of Cerebral Palsy and Developmental Medicine care pathway, we should typically consider using oral baclofen first line, and then second line trihexyphenidyl or Artane. And we often try to think of, or I try to think of medications where we can actually use the side effects to our advantage. So for example, clonidine can help with sleep. And so that may be helpful for people with dystonia and impaired sleep. If pain is more of an issue, then I may consider gabapentin. If a person maybe has seizures and dystonia or other increased tone, then clobazam may be a good choice, or Onfi. And sometimes a trial of a medication called Sinemet or carbidopa-levodopa may be performed, but this does not tend to be as effective in people with CP as it may be in other people with certain genetic dystonias. So if something else, though, to mention is that if somebody has a few specifically affected muscles that are impairing functioning, you can also consider doing botulinum toxin injections or Botox to those muscles to reach someone's individualized goals. And there are other medications sometimes considered, but these really tend to be the most common. And then when we think about surgical options, so essentially this comes about when there's somebody who has more generalized dystonia that's harder to control, or maybe we're running into significant side effects from oral medications such as sedation. We may consider surgical options. So like an intrathecal baclofen pump is one example where a neurosurgeon actually places a catheter into the spinal fluid to directly give baclofen. So hopefully to, minimize other systemic side effects that you could get. Yeah, it's really And so when a person has dystonia too, so intrathecal baclofen pumps may just be used for spasticity, but in people who have spasticity and dystonia, you can also consider it maybe even at a higher level in the spine. So maybe higher than you would otherwise do for spasticity only. And we are starting, this is very exciting. This is something I'm excited about myself. This is some work that I do, but we are starting to do more and more neuromodulation. So including deep brain stimulation, and need more studies to figure out how to identify ideal patients for this option. But DBS is a really exciting, I think, future direction that we're all doing a lot of work on right now in the field. And so with DBS, a neurosurgeon actually places electrodes into a deep part of the brain that, when stimulated, tells that part of the brain to reduce dystonia. So there's previously been, and still somewhat done, some other procedures that are what we call lesional, where that's called like a pallidotomy or a thalamotomy, where a neurosurgeon essentially goes in and kind of scars those deep parts of the brain that are also involved in dystonia. That's just more of a kind of a permanent procedure. And then it's also important to note, when we think about surgical options in general within people with CP, is that there can be surgery sometimes where dystonia becomes a relative contraindication to having a surgery. So one example of that is selective dorsal rhizotomy. And in a person with dystonia, what can happen is that the dystonia we don't really exactly know what happens, but it can be either unmasked or maybe just becomes more severe after a selective dorsal rhizotomy. So that's something to keep in mind as well, and to talk to your provider about if you're considering a selective dorsal rhizotomy.
Yeah.
Dystonia treatments, though, I mean, they'll continue to evolve, especially as we continue to learn more about what causes dystonia. And I think one really exciting avenue right now too is thinking about, as we learn more about genetic causes of CP and dystonia, that we may also begin to target individualized therapies based on these genetic findings. So a lot more research is needed, but also means a lot more exciting things to come. And then, as I mentioned, kind of that third pillar is really thinking about like rehabilitative or psychological options too. So this can include ways to improve comfort and stability. So thinking about like appropriate seating or orthotics. Also, something that can help with comfort is if a child is in school and has an aide or a para, maybe having the same person who knows them really well and can help minimize any triggers for them of their dystonia. And also thinking about other triggers to minimize. So things like making sure we're minimizing constipation, right? That can trigger dystonia. Right. And then also thinking about, from a therapy standpoint, really focusing on goal-directed therapies. And I know I mentioned this earlier too, but we know now that heightened emotions can trigger dystonia. And so things like anxiety or worry. So thinking about coping mechanisms, working with psychologists to do cognitive behavioral therapy, I think is also very important to consider, and probably not something we've done enough of in the past.
Yeah. And I'm reminded of a lot of this from that Peer Perspective series, which we have, which for people who are watching this now, is on YouTube, to kind of hear that, like you said, that caregiver perspective of how they manage and treat. And they made mention of all of these things, constipation, how that could be an issue, and excitable emotions. And sometimes just even like the physical environment, like even having like an object or presence like behind the head that makes his like arch back. So it's just interesting to hear that there are, you know, whether it's like you said, through medications, through surgical options, or some of those rehabilitative or psychological avenues that people may take to kind of mitigate some of those symptoms. And so I think it's very interesting. But I'm excited to hear that there is work that is happening, right? And and we are going to talk, I would say, in just a few minutes about some of those future advancements in research and clinical care. But for now, a hot topic is also, we hear a lot of parents in our community talk about status dystonicus and dystonic storming. So if you could help explain what those are, and just any other relevant information you think would help empower parents just with education about what it is and how to handle it and what that looks like in their daily lives.
Yeah, absolutely. This is incredibly important. So for people who have severe dystonia or more generalized dystonia, there is a risk of having an exacerbation of dystonia that can actually potentially be life-threatening and is considered a medical emergency. So this is what we call status dystonicus or dystonic storm. And it can really affect all ages, but typically we see it more in kind of this age range of about 5 years old to 16 years old or so. And if you notice an increase in severity of dystonia to where it's impacting your child's ability to lay or sit comfortably, maybe impacting sleep, they're irritable and cannot settle, they have signs maybe of dehydration or fever, or maybe starting to have difficulty with breathing, then I'd recommend discussing with your provider urgently and consider presenting to an emergency department for evaluation. And with status dystonicus, early recognition is really critical because it requires aggressive treatment up front. So clinicians may need to give IV medications like benzodiazepines, such as like Valium, or Precedex infusions, and sometimes maybe pain medications too. And then we also try to perform lab testing because we need to make sure that electrolytes look okay and that other organs like kidneys have not been affected by having prolonged increased tone. So worsening dystonia can eventually lead to exhaustion. I mean, you're using all these muscles sometimes for many hours or even days sometimes before presenting. And so it can lead to exhaustion, dehydration, increased body temperature, and it can eventually lead to respiratory compromise or failure. And so people may need to be supported in the ICU.
Wow.
Yeah. And so often this is triggered too. So triggers, probably the most common is infection, actually, but this can also occur from other things that cause discomfort, like we were mentioning. So constipation, but other things to think about are maybe reflux or other orthopedic concerns, like maybe there's a fracture that we haven't detected or hip displacement. So therefore, it's really important if somebody is having an exacerbation of dystonia to look for any potential triggers or underlying triggers, because it's really necessary. We need to try to correct those if we can. And sometimes, though, we may never find a trigger, but it is still important to look. And so overall, I want to stress that it's really important to speak with your team about having a rescue plan in place. So basically to have it available in the setting that this occurs so that care can be given quickly to prevent worsening dystonia. So sometimes this can be done. So we stop the dystonia from worsening to where you need to come into the hospital. So this may include giving maybe as needed benzodiazepines like diazepam, Valium, or perhaps maybe extra doses of clonidine, and calling the office to notify your provider if this is happening, if you're starting to see signs maybe of an exacerbation, so that it can be taken care of early.
And you had mentioned, sometimes this storming can be a shorter amount of time and sometimes it can last a longer time. Like, it's probably different for everyone. Is there like a range typically, or is there any way while you're in it to know how quick or how long prolonged this is going to be as it's happening, or no?
Yeah. So when people are presenting, oftentimes, if it's been several days, it could be maybe it wasn't recognized that there was some worsening of the tone, or, part of this has to do with awareness, right? If people don't know to look, they don't know what to do in the situation, and that we need to seek care early. And so that's why doing, Q&As like this can be really valuable to make sure that people know what to look for and recognize the signs. It tends to be that we do see that the longer it takes to get care, that can lead to more difficulty in controlling the dystonia overall in their course.
I see.
So sometimes they may be admitted for longer. And part of this is because the way that I think about dystonia is it's also sort of this vicious cycle where maybe pain is driving dystonia, but then dystonia creates more pain, which then drives more dystonia, and you get into this vicious cycle. And so it's all about breaking that cycle early, and sometimes needing added support like IV medications to be able to do that. Yeah.
And to reference again, those caregivers who spoke out, they said it took them years, some of them, to identify those triggers, right? So maybe it's just important for people who are tuning in to know that, like, it maybe the first time, if you don't catch it, like, to avoid the guilt of it, it's impossible of a task. That probably is, like a mom too. But but it might take a minute to understand what those triggers are to help be as proactive or to prevent as much as possible.
Right. And I would say we're trying to do more education on our end too, right? I mean, not all clinicians know what this is, and they don't know how to recognize it. And so we're trying to do a better job also of educating some of the first line clinicians, maybe like in the emergency department, like what signs to look for, when to call neurology for further guidance about a concern for status dystonicus or maybe impending status dystonicus.
You mentioned earlier that there are advancements, there's research when it comes to just breakthroughs with dystonia. So are there, from your perspective, any promising treatments or therapies on the horizon for dystonia management? We'll start there.
Yeah. So, this is a really exciting time to be working in the field of neurology because there are so many ongoing research projects looking at ways to improve the diagnosis and the management of people with dystonia and CP from really bench to bedside. And so we have physician scientists researching the, as I mentioned, like underlying genetics of dystonia and CP. There are some that are looking at biomarkers of people with CP who may perhaps respond optimally to certain treatments like deep brain stimulation. Within DBS, there is ongoing research about using recordings and stimulation to understand more about dystonia and how it works, and also use that information to then figure out if we can determine personalized targeting with DBS.
Mm-hmm.
There's also ongoing studies looking at other therapeutic options, such as something called focused ultrasound pallidotomy, which is a non-invasive technique. And then also some other surgical conversations around combined rhizotomies for people with spasticity and dystonia. And then also something interesting and always a hot topic too is that people are looking at the effects of cannabinoids or things like CBD on dystonia. And so there's much more work to be done, but many exciting things, I think, on the horizon.
Wonderful. And then given that HIE-acquired dystonia often doesn't respond to the same medications as some other causes of dystonia, are you able to speak on any research that's being done or management for dystonia that our HIE children face?
Yeah, so great question. And a large majority of dystonia research has historically focused on adult onset dystonias or genetic isolated dystonias. And more studies now, though, are specifically focusing on dystonia in people with CP for this reason, because they have unique needs. And CP is a very heterogeneous disorder, though, so it makes it challenging to understand why certain people may respond a certain way to a particular treatment, even when we look at specific etiologies, such as people with history of HIE. So overall, what we really need to be doing, and what people are starting to do now, is to do more trials comparing effectiveness of certain medications and people specifically within these subgroups. So perhaps like people with HIE and CP, and looking at outcomes like pain and function, reaching individualized goals, sleep, looking at side effects too, that are really particular to people with this same shared underlying risk factors. So as I mentioned before, there's ongoing research and looking at other like biomarkers. So one way that we're doing that is people are looking at particular imaging patterns, such as is seen with HIE, and also using, functional neuroimaging techniques too, to try to determine any potential responsiveness to DBS or other therapies. And then, I mentioned this a couple of times too, but also understanding genetic variations is really important as well. And I think this is hopefully going to one day lead to individualized treatments. And so I'm really excited to see where this genetic revolution takes us.
Yeah. And in the meantime, we always like to end on this note, just to give our community members just like a tangible piece of something or somewhere they can go to for help or education. Do you have any reliable resources, organizations, et cetera, that you would suggest to individuals or families who are affected by dystonia and just want to learn more? Or want to find support, or just have access to more information?
Yeah. And well, first of all, I want to point out that efforts like this are incredibly helpful to raise awareness of dystonia. So thank you again for setting up a wonderful Q&A today. Additionally, I want to put a plug in for CP Research Network, or cprn.org. It's another very helpful organization that has resources, including a CP toolkit, and has dedicated sections and webinars on dystonia and CP, as well as discussion forums on this topic. To name a few others, I would also recommend the Cerebral Palsy Foundation and United Cerebral Palsy. And then also the American Academy for Cerebral Palsy and Developmental Medicine is a really great organization to be connected with as well, and has exciting in-person conferences to attend where you can meet therapists, orthopedic surgeons, neurosurgeons, neurologists, physiatrists, all of these researchers. Everybody's in the same place with CP community members. So it's a really wonderful thing to, I think, be a part of as well. So yeah, those are probably the biggest ones that I can think of off the top of my head.
Wonderful. And for those of you who maybe aren't familiar or don't know where to go, we take resources like this and we put them, I mean, they're streamed, on our social channels, but we put them on our YouTube. We create blogs and key takeaways to share. And then with also links to some of those resources that you just mentioned, just to make it easier to find and to, again, equip our parents and empower them with some information and support if they find that they need it. So thank you for taking the time again to talk with us and just kind of shed a piece of light on dystonia and how we can help our parents. And we're just grateful that we have people like you who are so passionate about the work that they do for helping some family members all over, but specifically, right, for those in our HIE community. So thanks again.
Absolutely. And thank you all for the tremendous work that you're doing. And again, it was a privilege to be here today to chat with you. So thank you so much for this opportunity to cover this important topic with you all.
Appreciate it. Thank you.
Thank you.